a single shot CVP.
Yeah, I would say the extreme situation might help you. Very low CVP or extremely high is okay. They could be validated because you know that if your IVC is totally flat, they are volume down. If IVC is super plump, they are volume up. There is no doubt about how many times you see those extreme scenarios. Most of the time you fall in a middle category where you see your IVC is still okay, is little bit collapsibility is there, your LV is not super akinetic or dyskinetic, you're still fairly okay. And those situations, you're not able to decide whether they are volume down or volume up.
Hi. So when we see in a leg raise test, the VTI changes.
Yes.
So do we see between fluid responders and not responders, the VTI change with respiration?
No, so the good thing about the passive leg, you can do with a spontaneous breathing patient as well as mechanical vent patient. The beauty is, and if the patient has not in that Frank-style income, not in that steep area, even if with the leg rising test, their stroke volume will not increase.
Okay, so not with the respiration we go with.
No.
Okay.
It's validated for both, and it's very easy and it's a bedside.
Thank you. Anyone from the audience?
Serial IVC? No, ma'am. See, this is not anymore what we're going to achieve with the IVC. What we are aims to achieve by measuring the IVC. No, we cannot. That's what we all talked about, IVC measurement. Even if horizontal, you see the diameter, and even if you cannot have by measuring the IVC, rough, that's what I told most of the patient, you can have the extreme values are you helpful. If your IVC is flat, it's just kissing, they are volume down. Your IVC is not moving at all, it is plump, they are helpful. But how many times you fall in that category? Rarely, in 10 or 20%. Most of the time you see the patient in practice where their IVC is still moving. And one more thing, the people always get confused with the concept of IVC compressibility. Yeah, so IVC is by physiology itself, when patient is on vent, IVC is IVC is not going to collapse, IVC is going to dilate it. Because it's holding, because we are generating a positive pressure in the chest, it is stopping your venous return. So basically the effect of bend on IVC is to make the IVC dilated. So concept of compressibility is lost where you see the concept of distensibility. So IVC distensibility is the concept for vented patient. If you're talking about IVC is compressed in a vent patient, you are not making any sense. You have to talk about distensibility.
Actually, a few months back, I attended the Rajasthan Criticon as faculty. So there was a speaker who said that if you want to go for IVC measurement, just disconnect the ventilator for few seconds.
Disconnect the ventilator for 4 seconds. That
no, we are doing it.
Even if then you made the patient spontaneous breathing, right?
Yeah, and we are doing it for many purposes.
But even for the spontaneous breathing, ma'am, you can only have an idea of CBP. Again, I'm repeating. And by CBP is not itself validated a preload indices. It is a just.
We are just ready with the focus. We are just ready with the probe. This is what it was discussed, and like you only, we were in a lot of discussion.
You made the patient spontaneous breathing, and that also can give you an idea.
It was an idea. It was suggested. It was very well taken up by some audience, but not all.
Could be, possibly. Any questions, sir?
Dr. Niranjan sir will be connecting online little later from Hyderabad. He's busy. And that was truly a helpful and educational session. Please collect your mementos from Memento Station.
Delving further inside, our next topic for the case discussion is on atrial fibrillation in ICU setting. We are delighted to welcome our esteemed panelist,
Dr. Puneet Rijwani, Professor and HOD Medicine, Mahatma Gandhi Hospital, Jaipur.
Dr. Saurabh Taneja Sir, Senior Consultant, Critical Care Medicine from Sir Ganga Ram Hospital.
Dr. Nitin Kansal Sir, Medical Director and Head of the Department Cardiology, Durlabji Hospital, Jaipur.
Dr. Ashish Jain Sir, Director and Professor, Critical Care Medicine from Mahatma Gandhi Hospital, Jaipur.
It is an honor to welcome Dr. Mukesh Rundla, Consultant Intensivist, Critical Care Medicine, Santokba Durlabji Memorial Hospital, Jaipur, who will be guiding us through the discussion.
A warm round of applause for all of them as they take us through this engaging and insightful discussion.
Good afternoon to everyone. So I'll start with the case. A 68-year-old male, smoker, hypertensive, diabetic, post-PTCX status, admitted with SOB, dizziness and palpitation. On examinations, patient is hypotensive, 88 by 54 BP, heart rate 186, irregular, slightly tachypneic with a 28 respiratory rate. Hypoxemic, 84% saturation on room air, and the X-ray suggestive of a pneumonia. ABG showing mild respiratory glossis, and ECG is showing irregular rhythm without P waves. It's a case of atrial fibrillation with fast ventricular rate. So I'll start with question. So recently there is a change in the definition. The AHA, American Heart Association, changed the term secondary AF to acute AF. So how it's linked to future recurrence and the need for the long-term follow-up. I request Dr. Ashish Jain to comment on this question, please.
As the name is depicting that secondary AF, that means it is because of some disease or it is because of some illness or may be attributable to that illness. So now AHA has changed the secondary AF because it is mildly, oftenly unclear that it is during a disease or disease has become because of that. So now the terminology is acute AF. Acute AF is the AF which is diagnosed first during the acute illness. It may be present before the disease, but it is undiagnosed. So, and the one more thing, AHA tell about acute AF that it can be, it has a high level of recurrence. So long-term follow-up should be required for that.
So, like initially it was considered that acute AF does not have any recurrence rates. It occurs in the critical ill settings and then there is no need to go for a follow-up. But now this acute AF reflects AF detected during an acute illness, but it may be previously unrecognized. The recurrence rate, yes, it is not very high, but patient needs very high long-term recurrence rates are, so they need a follow-up. It is also related to the outcomes. It badly affects the parameters like morbidity, mortality, and longer hospital stay. So I'll continue with the case. The further history reveals that the patient had no prior episodes of AF. He recently developed fever and cough and was diagnosed with right lower zone pneumonia on an X-ray. His lab shows hypokalemia, possibly could be a trigger, and a respiratory alkalosis on the ABG. So in this setting, now acute infection, hypoxemia, and AF. how do we distinguish between the chronic substrate and acute triggers? And why it is important to understand these situations, these interactions? Dr. Ashish, please.
Substrate, chronic substrate, and acute triggers. Actually, a chronic substrate is just like a ground. That is a pro-arrhythmogenic substrate ground, in which arrhythmogenic seed of acute trigger gives acute AF in this condition. So, what is chronic substrate? Chronic substrate is primarily atrial scar or atrial fibrosis because of many reasons. Long term, like volume overload or valvular heart disease, or chronic conditions like hypertension, CKD, and maybe because of previous cardiac surgery, the scars are there. So this scar is a ground for that AF. But the acute triggers are electrolyte imbalance, infection, inflammation, change in the autonomic tone. So when there is a trigger on a substrate, there is a AF. And one more thing I want to tell you, that during in sepsis or during any infection, there are multiple animal studies have been done, that the bacteria deposits in the atrial myocardium and gives a inflammatory response in that, and it will lead to fibrosis. So if there is only trigger without a substrate, it is usually self-limiting. And but if there is a substrate, it should be treated. It is treatable actually, but it will we have to consider long-term follow-up because the recurrence rate is very high.
Thank you. So what is important, since we are dealing with the case of AF in acute care settings, so chronic substrates are ground for the AF. So in a critically ill patients, it's very difficult to reverse all these problems in a short span of time. So the target is to reverse and treat the acute triggers. These are the sparks like sepsis, catecholamines, hypoxemia, volume overload, electrolyte disturbances. So any AF in a critically ill patient needs that we have to target the acute triggers. Chronic substrates, very difficult to reverse. They need a long-term chronic management. Since for an intensivist, the important is to target the acute triggers. So the trigger-driven AF resolves with the cause. If it is substrate-driven, then it needs long-term control and anticoagulation. So treating only one without considering the other can lead to the recurrence or complications. So in a long-term follow-up, the important is to modify the chronic triggers, and in chronic substrate and in ICU patients, the important is to target the acute triggers. So these are the acute triggers important particularly for the non-medical ICUs like sepsis, inotropes, bleeding, volume overload or hypovolemia, patients on post-procedural pulmonary complications, electrolyte disturbances, inflammation, oxidative stress. So this is very important to target, and probably this is the only point which can be reversed, and that will probably help in the achieving normal sinus rhythm. So we'll continue with the case. Patient was in ICU, suddenly became more dyspneic with fall in blood pressure. Heart rate was still 180, 190. Saturation again dropped. Patient was taken on oxygen therapy. And with this BP and heart rate, a DC cardioversion was performed successfully. Again, AF recur after 30 minutes of the cardioversion. And for that, an IV amiodarone bolus was given and followed by infusion. So one comment, I request Nitin Kansal sir to add something for apart from amiodarone. This is a commonly used drug, but any other drugs which can be used?
Yeah, so I would like you to go back on one slide, one more slide, where you had shown the triggers and this thing. You are going forward, go back. Oh, so it's not allowed, it seems, huh? Okay.
No, it's working, sir.
Okay, so what I would like to, highlight here is, you have very nicely pointed out that if there is a chronic trigger like the cardiac issues, or a chronic pulmonary issue, which is basically putting your patient at high risk for atrial fibrillation. That is the case where you need to think about chronic anticoagulation and AF rate control or rhythm control.
Okay.
But if patient does not have any chronic triggers and it's an acute event, then it's the question whether we need to continue with chronic anticoagulation. And the answer to that, I would say, is possibly no. Because if you look at a person who is like 33 years old, has come to you with a respiratory tract infection, has gone into atrial fibrillation, would you put him on any anticoagulation? You would not.
Yes.
Because that patient would basically be in Chad's score of 0, or Chad's VASCOF also 0 if he is not a female. Right? And even if it's a female, the score is 1, you can still put them only on no anticoagulation. So that's the whole point. I mean, you need to see the clinical scenario and then decide whether you need to give an anticoagulation. As far as amiodarone is concerned, amiodarone is considered to be a drug which is good for conversion. I mean, it's not considered to be a good drug for rate control or for conversion to sinus rhythm. It is considered to be a good drug to maintain sinus rhythm. For conversion to sinus rhythm, there are other drugs like ibutilide and even IV drugs are there, like dofetilide is also there. But the only problem with these drugs is they cause significant QT prolongation. And you have to be very, very cautious when you're giving these medicines that patient does not develop QT prolongation, because then he goes into malignant arrhythmias like ventricular fibrillation and torsades, and they stay in that situation for a very long time till that effect of that drug or the QT starts coming down. So if you ask me practically, you have only amiodarone, which needs to be given for control of rhythm if you're targeting rhythm control. But when you want to maintain sinus rhythm, I think amiodarone is a better drug than any other drug.
I'll continue with amiodarone again, sir. So since it's a most commonly cardiac medication in non-cardiac ICUs, so when you are giving IV amiodarone for rate or rhythm control, what key precautions and monitoring steps should be followed to ensure safe use, particularly in critically ill patients?
Okay, so your critically ill patient tends to have multiple medications on, and many of those medications can be QT prolonging drugs, especially your antifungal medications, your cisapride, mozapride, those kind of medications, plus some antibiotics also cause QT prolongation. So you should be very well aware of all the medicines. There is a list of medicines on your internet which actually shows which all medicines have high risk of QT prolongation. And if you have all of them or some of them on board, you'll have to be cautious when you're using amiodarone. Secondly, you have to be very, very cognizant of the fact that hypokalemia is not tolerated very well in presence of amiodarone, and plus other medicines which are causing QT prolongation. So you have to be keeping your potassium levels between 4.5 or above if required, plus magnesium levels should be normal, because hypomagnesemia sometimes present only as QT prolongation, and hypomagnesemia and hypokalemia usually go hand in hand. So these are few things which need to be looked into, and then only you should plan amiodarone.
So while using amiodarone, we have to be very careful that our patient is not on any other drug which prolongs QT interval. The IV formulations, because of that preservative, causes sometimes hypotension and bradycardia. And the most important is the drug interactions, particularly with digoxin and warfarin levels. So amiodarone can significantly increase the blood levels of digoxin and warfarin, but most important is there should not be any concurrent use of other drug which prolongs QT interval. Apart from that, some other electrolyte disturbances like hypokalemia, hypomagnesemia and hypocalcemia. So these are the main concerns while using amiodarone. So during electrical cardioversion for AF, why must the shock be synchronized, sir? And why it is important to obtain a consent before the procedure? Consent.
Okay, so we give synchronized cardioversion in all cardioversions which are given for rhythm abnormalities except VF. So if you have VF where you do not have a definite QRS, in that you would not synchronize it. In all other cardioversions you have to synchronize it, because the last 1/3 of T wave is a phase where the repolarization abnormalities are in the most volatile state. And if your cardioversion falls on the terminal 1/3 of T wave, it can actually trigger ventricular fibrillation in those patients. So that is why if you have a definite QRS in your rhythm, you have to synchronize it. It is as simple as that. Informed consent is required because it leads to sudden stoppage of the heart and then it starts working again. So any thrombus that is there can actually migrate from there and cause stroke. So that definitely needs to be pointed out. Plus all the hearts which are very sick can sometimes have problems when restarting after the shock, because what we do in a shock is you electrically stimulate all the cells of the heart at the same time, and then they have to come out of it and start beating on their own, and the site which starts the first usually leads the path in the whole of ECG. So and that is usually the SA node, because that has the shortest refractory period. So I think if your heart suddenly stops and your heart is a very weak heart, sometimes it may not come out and may go into refractory shocks. So these need to be definitely informed the patient.
So it has to be a synchronized cardioversion, and we have to make sure that we have given a command to the defibrillator that the defibrillator is going to give a synchronized cardioversion. That means the shock delivery, the defib will give a shock delivery at the peak of the R wave. Few more questions, sir. So in acute AF, the management follows the 3A, so acute triggers, rate rhythm, and the anticoagulation. So how does this approach differ between a stable patient and a hemodynamically unstable patient? It's also
So in a hemodynamically unstable patient, definitely you have only one choice, and that is cardioversion, so that you are able to bring the patient back to normal sinus rhythm, and which may help the patient in becoming hemodynamically stable. And this is especially important in patients who need atrial kick for maintaining cardiac output, like patients who have mitral stenosis or aortic stenosis or concentric LVH, where the atrial kick does help. Having said that, of course, mitral stenosis or chronic valvular heart diseases which have very large LAs, we don't usually cardiovert them because we know they won't come back to sinus rhythm. But hemodynamically unstable, you will have to anyway go that route. In a stable patient, you have all the ways to manage it.
Thank you, sir. So in an unstable patient, the only option is electrical cardioversion. In a stable patient, we can wait and watch, and the approach depends on whether we need a rate control or rhythm control. Now, the commonest discussion in AF in intensive care unit is the target rate control. If it is 110 or 130 or 150, the one concept you all understand that the cardiac output in critical ill patients is rate dependent. So any rate less than 110 is generally not recommended. So rate control is less than 110 beats per minute if the patient has a normal LV, and patients with LV dysfunction, the target we can go up to 80. So less than 80 beats per minute for a patient who has got LV dysfunction. Sir, on this point also I need your comment. A cardiac patient with a medical problem and a non-cardiac patient with a medical problem. So is there any difference in the target rates?
See, in a patient who is chronic heart failure, we tend to give them beta blockers and try to keep their heart rates at around 60 to 70 beats per minute, and that is because we want to cut the compensatory mechanisms that are working in a heart failure patient, which tends to further cause heart failure. But in a patient who does not have a cardiac illness and has come to you with a situation where he has a low cardiac output or a low stroke volume, you need a higher heart rate to maintain cardiac output. If the stroke volume is low because of whatever reason, let's say it is myocarditis or it is because of any other reason, in those cases, if you bring the heart rate significantly down or less than 80 or less than 62, then chances are that the patient will have a hemodynamic compromise. So no cardiac illness, I would not come down on heart rates less than 110 for sure.
So for cardiac patients,
For cardiac patients, you have to basically weigh the benefit of having a higher heart rate versus the downside of it. Usually in acute illness, you need to target the the protocols that or the guidelines that you have in the critical care.
Okay, sir. So this is the algorithm what we have discussed. Now we'll continue with the case scenario. After stabilization, rhythm control was achieved and the patient's BP improves to 110/70. Since the AF duration is estimated to be less than 24 hours, and the cardioversion was performed early. So now the question about the duration of the AF. Initially it was considered that if your duration of the atrial fibrillation is less than 48 hours, then the risk of clot formation and the risk of thrombotic complications with the cardioversion is less, practically not. But now the recent data suggests that even if the duration of your AF is less than 48 hours, then also there is a risk of clot formation, and with cardioversion there is a risk of thrombotic complications. So I want a comment, Nitin Kansal sir, Puneet sir, why they changed the window of 48 hours to 24 hours.
Okay, so I think there was a study in patients who had a device in, like a pacemaker or an ICD, and they were subsequently seen to have atrial high rate episodes, which was considered to be equivalent to atrial fibrillation, and they were monitored from 8 hours or 6 hours to 24 hours or more than 24 hours. So all the patients who had AF of 24 hours or more or atrial high rate of 24 hours or more had higher chances of thromboembolism, and possibly they have extrapolated it to atrial fibrillation of less than 24 or more than 24 hours. I'm not sure about whether that's the case or it is because they have done a study where they have seen that less than 48 hours or more than 24 hours it also causes more of thromboembolic phenomena. But anyways, all these patients, anyway, you have to give IV anticoagulation before cardioverting, and you have to anticoagulate them for at least 4 to 6 weeks post cardioversion because the atria is stunned, and therefore you need anticoagulation anyways. The only question is whether you want to do a TE or you don't want to do a TE in these patients. So that again comes only if the patient is hemodynamically stable. If he is unstable, you anyway are not going to do a TE. You are anyway going to cardiovert him.
So now the prediction and the stratification for the thrombotic risk, it depends more on the CHADS, less on the duration of the AF.
Any AF, if you are cardioverting, you have to anyway anticoagulate them.
Okay.
If it is more than 48 hours, it is ideal to anticoagulate them for at least, I think, 4 weeks, bring them back, cardiovert, and then continue anticoagulation for 4 to 6 weeks. If it is less than 48 hours, initially we were expected to do a transesophageal echo, see whether there is an LA clot or LAA clot, and if it is not there, you could cardiovert after giving IV anticoagulation, then continue anticoagulation. So I think the only question that is left is whether we need to do a transesophageal echo. So that maybe from 24 hours, from 48 hours, we have to come down to 24 hours. I think it has not come in the guidelines though.
Thank you, sir.
Right now, actually, AHA recommends that if AF is of less than 12 hours durations, then there is no need of, you can go through like for cardioversion. But now AHA recommend that if the AF is of more than 12 hours duration, and then we have to see the Chad West score also. If it is in the vulnerable, like more than 3 in the female or more than 2 in the male, and patient is stable, it is better to do a TE to rule out thrombus. Obviously, for post cardioversion anticoagulant should be continued, but to see the to rule out the thrombotic thrombosis post cardioversion, we have to do a TE.
Okay, thank you, sir. So this is what we have discussed. It's a pre-cardioversion, 3 weeks. Then we'll continue cardioversion 4 weeks after cardioversion. Now, what is the important point of discussion? We are dealing with the case of atrial fibrillation in a critically ill patient. So, in sepsis or acute stroke, when and how should anticoagulation be initiated? Dr. Puneet, sir, please.
See, one should not be in a hurry to start anticoagulation, especially in patients of sepsis and acute stroke, because we have to balance the thromboembolic risk with high risk of bleeding, as we see in all these patients, because of thrombocytopenia, because of coagulopathy, because of invasive procedures. So one should try to stabilize these patients, correct the electrolytes, correct hypoxia. One should go for rate control, and when the patient stabilizes, then we have to reassess these patients. Still, there is AF in these patients, or if the Chadwell score is high, then definitely after stabilization, we should start anticoagulation, as many of the patients in which atrial fibrillation gets reverted, there are chances that 20 to 50% of the patients, of these patients, will develop atrial fibrillation over a period of 1 year. So we have to assess the risk and start anticoagulation. And if we talk about acute stroke, it is the same. One should not anticoagulate these patients in the acute setting, especially in the first 48 hours. And after 48 hours, the anticoagulation depends on the severity of the stroke, the size of the infarct. Severity, it depends on the NIHS scoring. If it is less than 8, then we can start anticoagulation at day 3. If it is moderate, 8 to 15, then one should start anticoagulation. There is a rule 3, 6, and 12. Moderate stroke, then after 6 days, and severe stroke after 12 days. But yes, before starting anticoagulation, one should go for rescanning whether the patient has developed hemorrhagic conversion or not.
So the discussion of anticoagulation is basically limited for a chronic compensated cardiac patient. In an intensive care unit, actually does not need lots of discussion and when and how to start anticoagulation, because there is other factors. Patients are actually at risk of bleeding, so that is entirely different for a critically ill patients. So in sepsis, rate control is preferred, as with cardioversion the relapse is very, very common because of the acute triggers. And sir, as already mentioned, in ischemic stroke, it depends on the severity of the stroke. In a major stroke, since the bleeding risk is very high, so we can wait up to 2 weeks. So after cardioversion, the patient remains in a sinus rhythm, BP stabilizes, patient was afebrile. So again, one more question about anticoagulation, sir. Should be initiated or deferred? And the most important question which we always deal in a ICU patient, and that is about the reliability of CHEDS score. CHEDS is one score which has been studied extensively in chronic compensated cardiac patients. So the relevance and the validity of CHEDS is questioned in a patient who is in ICU and where there are many, many acute triggers. So sir, how relevant is score in ICU patients?
Actually, Chadwell score definitely has a relevance in stroke prophylaxis, but not in the acute setting. In the acute setting, this may guide the prognostication of the patient. But we should follow this score after the patient stabilizes. As I already said, that all these patients tend to develop this atrial fibrillation in next 1 year. So once the patient stabilizes, definitely we should follow this score and start anticoagulation, especially in men if it is 2 or more than 2, and in women if it is 3 and more than 3.
Thank you, sir. So these are the limitations in acute settings. Chats alone poorly predict the score risk. So along with that, we have to consider all other factors: bleeding risk, thrombocytopenia, coagulopathy, and probably then also it's actually not very easy to start anticoagulation based on the chats. So this is for chronic compensated cardiac patients. My last, probably second last question. One comment, Taneja sir, why is rhythm monitoring is vital, and which risk factors needs modification to reduce the AF burden?
So the patients who are actually having high risk factors for AF, who have already have AF, who are on treatment for AF, we should monitor their rhythm, because they can have a paroxysmal AF, some unmonitored AF, which can actually lead to increased chance of stroke. So decrease the chance of stroke, we should monitor their rhythm. And if you talk about risk factor modifications, we should target there if there are any basic disease like cardiac disease or thyroid disease. Then lifestyle modifications, avoid alcohol, smoking. Then if they have sleep apnea, we should get them treated for sleep apnea. So all these factors should be modified as much as possible and monitored, because to decrease the chances of stroke.
Thank you, sir. So we'll end this discussion with the last and probably the most important discussion: when to do a echo, and can echo give some information that which therapy is going to be helpful, whether the rate control or the rhythm control. So based on the echo findings, sometimes it's very easy to predict that probably this patient will not respond to any rhythm control therapy, and in that patient probably the rate control is better. So again, this final question, Dr. Taneja sir, final comment.
I think you should show the algorithm and you should go through the algorithm, because it will be clearer for all of you. So idea is to check the left ventricular ejection fraction and then the LAVI, which is the left atrial volume index. So any patient who has LVEF of less than 35% and LAVI of more than 40%, we go for rate control. And whereas LVEF of, you can show the algorithm.
Yes, sir, it's on the screen.
And any patient, when we talk about rhythm control, we talk about that patient should not have any valvular disease, or it should be of new onset. And when the patient is hemodynamically unstable, we take into account the LAVI.
Thank you,
You'll show that, yeah.
So it is the, sir has already mentioned, it's the left atrium volume index, the most important determinant. Apart from that, any absence of valvular disease, or if your patient is on very high supports of catecholamines, if these factors are present, possibly my patient will respond better to the rhythm control therapies. In the absence of this, or in the presence of all these problems, my patient is probably not going to respond to the rhythm control therapy. So in this case, in this scenario, probably the rhythm control would be a better option when the LA is dilated, when the LA velocity index is more than 48, the end-diastolic diameter is more than 46, and if there is underlying severe valvular disease and severe LV dysfunction. So in these scenarios, probably my patient will respond better to the rate control therapy. Otherwise, rhythm control can be achieved. So I end my session. Thank you so much.
I would like to make a small comment here. What we need to look at when a patient is in ICU is to look at reversible factors.
Yes.
Like if a patient has come with an acute coronary syndrome and has gone into atrial fibrillation because the left atrial branch got occluded while performing a procedure or not even performing a procedure, and he goes into atrial fibrillation, he will revert back to sinus rhythm either on his own or with the assistance of either cardioversion or chemical cardioversion. But does he need chronic anticoagulation and chronic rhythm management? The answer is no. Similarly, if you have a reversible cause like an acute pulmonary cause causing an atrial fibrillation, but he does not have any triggers at all, then do we need to maintain sinus rhythm by giving him antiarrhythmics is again a question. So what I mean to say is you need to look at the reversible causes versus chronic triggers. Clearly, you have mentioned LA size being large, valvular heart disease being present, chronic pulmonary disease being present, which would cause higher chances of recurrence of atrial fibrillation. They definitely need these things. And that is where you need to look at the CHADS-VASc score. Any patient who has atrial fibrillation, has no chronic triggers, is like a lone atrial fibrillation. And we manage lone atrial fibrillation based on CHADS-VASc score. If the scores are low, we don't give anticoagulation to them. And lone atrial fibrillation, until unless he's symptomatic, we don't even treat them.
Thank you, sir. Thank you so much for all comments, sir. Any questions? Probably no.
That was indeed a very engaging and knowledgeable session. I thank you, our esteemed chairpersons. I thank you, our esteemed chairperson and our esteemed faculty, and request them to collect their mementos from the station outside Hall A.
Now let's move on to a very important topic, that is neurocritical care. Quintessential fusion of neuroscience and intensive medicine, where every second, every neuron, and every decision can redefine recovery. The first subtopic for the didactic lecture on neurocritical care is essentials of status epilepticus in ICU.
I would like to invite on stage our respected chairpersons, Dr. D.C. Gupta sir, Senior Consultant and Director, Pulmonary Medicine at Mangalam Plus Medicity. Dr. Adarsh Swami sir, HOD, Anesthesiology and Pain from SMS Medical College, Jaipur.
Dr. Priya Agrawal ma'am, Senior Consultant, HOD, Department of Neurology, SDM at Jaipur.
Dr. Priyamvada Gupta ma'am, Professor, Director of Obstetrics and Gynecology Anesthesia from Mahatma Gandhi Hospital, Jaipur. And Dr. Sana ma'am, Consultant Intensivist from RHL Hospital, Jaipur.
Hello. So I would like to invite Dr. Bharat Paliwal for the lecture on the essential of status epilepticus.
Good afternoon, respected chairpersons. Good afternoon, friends. So I will be discussing about status epilepticus in ICU. So to begin with, it's a just to specify, it's not a disease entity in itself, but it's a symptom with a myriad of etiologies. So status epilepticus is a life-threatening emergency that is characterized by prolonged and recurrent episodes of seizures without recovery in between those episodes. And it is important because it can lead to irreversible neurological injury and has a wide implications on mortality and morbidity. So classically, the definition carries all these elements, but the limiting factor is what is that brief interval, or what is the interval that has not been specified. And because of this, they have various operational definitions in several textbooks and literatures, and even in clinical trials. To mitigate this, the international task force, they had given up the definition of status epilepticus. It is more of an operational definitions, and they had categorized it into 2 time points. First time point is the time point T1, which mention is as a status epilepticus as a condition of failure of mechanisms responsible for seizure termination or initiation of mechanisms that leads to these abnormal prolonged seizures. And the time point 2, which is significant because it denotes the severity of illness or how rapidity you need to intervene to prevent that long-term complications. So based on this, they had classified the seizures as tonic-clonic focal status epilepticus with impaired consciousness and even absent status epilepticus. The time zone varies with the type of the seizures from 5 minutes to 15 minutes for the T1, and for the T2 it measures from 30 minutes to more than 60 minutes. So this is the T2 important because we have to achieve the control of seizures to prevent long-term morbidity and mortality. So what this task force had come up is, they had categorized all seizures based on 4 axes. First off is the seminology, or what is we called as the clinical presentation of the. Second is the etiology. Third is the what are the EEG correlates associated with them. And fourth factor they have categorized is the age. So the foremost important is the seminology or the clinical presentation. It is the backbone of these classifications, and it is based on 2 taxonomic features. First of them is the presence or absence of the motor symptoms, and second is the presence and absence of altered mental status. So based on this, they had classified it as a status epilepticus with prominent motor symptoms, in which they have categorized convulsive status epilepticus, myoclonic, focal motor, tonic statisticus, and hyperkinetic status epilepticus. And those without the motor symptoms, they had classified into non-convulsive status epilepticus with or without coma. So second axis is the etiology. So if we go through the etiology, it will be difficult to read out all, and even this list is not complete. You may still find many other features. So what this task force has done is, they have categorized it into 2. One is known with a symptomatic etiology, and those they are unknown, that is the cryptic etiology. They are further classified it into acute, remote, progressive, as well as the status epilepticus in defined electroclinical syndromes. I am not going to read about in the interest of time, but to just brief out that they have reduced the classification into the simple categories. What I want to highlight is that they had removed the term idiopathic or genetic from this classification. Coming on to the third axis, that is the electroencephalographic correlates. So there is no defined criteria to classify based on the EEG, but based on large descriptive studies and consensus panel, they had come up that the status epilepticus should be categorized based on the following subcategories like location, whether it is a generalized, a lateralized, there is a bilateral, independent, or multifocal. Based on the pattern, where there are periodic discharges, rhythmic delta activity, or there are spikes and wave patterns. Based on the morphology that consists of phase, amplitude, polarity, etc. Time-related features like onset, duration, progression, and frequency. Modulation, like whether it was spontaneous or whether induced with any stimulus, and what were the effect of any interventions or any medications on the EEG parameters. So these were the 3 axes. The 4th axis is the age factors. Again, they had classified based on the age into neonatal, infancy, childhood, adolescent, or elderly. These are the broad classifications. So entire classification rests on these 4 axes, and this simplifies the categorization of the status epilepticus. So we have broadly known it as convulsive or non-convulsive, but this task force has further clarified the definition, which we have some ambiguity till now. So according to them, they had categorized as early or impending status epilepticus when the seizure duration lasts for more than 5 minutes without recovery of consciousness in between. Established status epilepticus when this status epilepticus does not respond to the first line therapy, that is the benzodiazepines. Refractory status epilepticus, that is status epilepticus that does not respond to 2 anti-epileptic drugs, one of which is the first line, that is the benzodiazepines. And prolonged refractory epilepticus, that means a status epilepticus that persists for more than 7 days despite appropriate management, but In this, we had not considered the third line, that is the use of anesthetic agents. There are few more terms like super-refractory status epilepticus, that is a status epilepticus that lasts for more than 24 hours, even after initiation of IV anesthetic agents or after their termination or interruption of the infusion of IV anesthetic agents or after the withdrawal of anti-epileptic drugs requiring reinitiation of the anesthetic drugs. Another definition they had given is the prolonged super-refractory status epilepticus that is refractory to all measures and it persists for at least 7 days. So these are the basis consensus definitions they have given. There are two more terms which I would like to discuss. One is the new onset refractory status epilepticus. So this entity is the one where you do not find a clear established diagnosis. There is no relevant neurological disorders, and it is a new onset refractory status epilepticus without any without identifiable cause. Although I say there is a no clear identifiable cause, but in majority of such cases, it is usually the viral etiology or the autoimmune etiology that leads to this. And there is a special type of this NORSE that is known as the FIRES or the febrile infection related epilepsy syndrome. So what distinguishes this is that this category involves there is a preceding any febrile illness before this status epilepticus that may precede at least 2 weeks or up to 24 hours prior to that epilepsy. And it is not necessary that during the episode of status epilepticus the patient may have fever. What is mandatory requirement is that there should be an episode of fever at least 24 hours prior to 2 weeks prior. So these are the consensus definition. Coming on to the pathology of the status, so there are several receptors involved in the etiology of this. The common ones includes the GABA type A receptors, the NMDA type A receptors, the AMP receptors, some calcium dependent mechanisms, and the potassium chloride co-transporters. So these are the common pathology involved in it. What should be our diagnostic workup? So it should be history taking is always a paramount importance. Our previous speakers have also highlighted on the importance of the history taking. A regular bedside clinical examination, this should be supported by relevant investigations and imaging. What about the EEG? So EEG, there is a whether it should be a continuous EEG monitoring or there should be an intermittent EEG monitoring. So recent RCTs that had come out that they have an equal response because none of those RCTs had studied the long-term mortality or morbidity implications. What they had said that they have an equal effect. So those where the facility of continuous EEG monitoring is not there, they can do it intermittent EEG monitoring at a 12-hourly interval. So other investigation, routine investigations like CBC, LFT, KFT, because they may have some modifiable causes, so we should go about this. ABG, we should work out for the infectious causes, and LP with routine biochemistry, serology has to be sent. Metabolic workup includes those of thyroid profile and looking for an ammonia levels. Toxicological screening based on the history if you suspect some toxicological factors in it, and baseline imaging based on the history like CT or an MRI. So what I was talking about was EEG, that you may have a resource setting where continuous EEG may be easy. So almost all patients suspected or proven epilepsy, you can do a continuous EEG monitoring. Those with which have a lower resource setting, sorry. So those are limited. So this width of this symbol indicates the spectrum across which you may use the continuous EEG, whereas their position with respect to the disease etiology says where it should be done. So in limited resource setting, in a proven or a super refractory state, you should go for a continuous EEG, whereas in high resource setting, you may invariably use for those who are either having status epilepticus or suspected to have those. So coming on to the treatment part, so first line of the treatment always starts with the ABC. You have to maintain airway breathing circulation. look for the correctable or reversible causes like glucose or serum electrolytes. Benzodiazepines are the first line of management, and the most common used drugs are lorazepam, diazepam, or the midazolam. If the seizure persists beyond 5 minutes, you have to give a second dose for that. In case these first line drugs are not available, you may choose on for an IV or IM phenobarbital or a levetiracetam. All routes may be used. If IV access is not available, these 3 drugs can be used through buccal, intranasal, rectal routes as well, with appropriate dose modifications. Second line drugs starts if you are not able to control seizures for next 10 to 20 minutes. And as per the task force, there is no specific second line agent. So you may use phenytoin, fosphenytoin, sodium valproate, or levetiracetam as per the drug available. Coming on to the criteria for ICU admission, if the patient requires intubation, mechanical ventilations, either because of aspiration or altered sensorium or threatened airway, or there is a respiratory depression resulting out of your interventions, or because of continued escalation of medication, the patient requires monitoring, the patient may be shifted to ICU. Coming on to the third line drugs, so these are mostly the anesthetic agents like midazolam, propofol, ketamine, thiopental, pentobarbitol. So these have to be administered if you are not able to control how to titrate. There are 3 methods. So coming on to the burst suppression on EEG, you have to maintain it for 24 to 48 hours. Otherwise, you can go on for checking the electrographic cessation is there or not. Those where EEG monitoring facility is not available, you can continue to go for an antiepileptic infusions for next 24 to 48 hours. Always ensure that after 48 hours when you will be withdrawing the IV drugs, so better to switch on to the long-term medications and achieve an adequate serum control before the drugs are withdrawn. Otherwise, it may provoke the status epilepticus. And the intermittent EEG monitoring I had already talked about. Coming on to some other factors like autoimmune etiology, where there is a role of immunotherapy. The part is that you should initiate within 72 hours for the better prognosis. Pulse IV steroids as well immunoglobulins have been tried with good results. Make sure the other measures include a use of a ketogenic diet. Second line immunotherapy agents includes plasmapheresis, rituximab, tocilizumab, cyclophosphamide, and IL-1 receptor antagonist anakinra, or bortezomib, that is a proteasome inhibitor. These are second line immunotherapy drugs. Coming on to the need for tracheostomy, generally if the intubation is required for more than 7 days, decision of tracheostomy can be made. Maintain the vitals with mean arterial pressures more than 65 millimeters of mercury. Remember not to withhold any third line drugs just for measuring the neurological assessment. So that is the message from the task force. Continue glucose monitoring, electrolyte monitoring, enteral nutrition, thromboprophylaxis, prevention of hospital acquired infections. So this is just a timeline how to go about it. So first, after securing airway breathing circulation, over next 15 minutes, you have to use the first line drugs. Not able to control in next 5 to 10 minutes, go on for the second dose. Next, if you are not able to control, go on to the second line drugs. Finally, within the first hour, you should be able to control it. If not, then you go for the third line drugs. What beyond 60 minutes, then you can consider adding more of second line drugs in convulsive status epilepticus. In non-convulsive status, you may add on to the, after 60 minutes, you can consider for a third line drugs like all anesthetic drugs. And immunotherapies may be considered for nausea and fires. So prognosis, it always depends on the underlying cause. A correctable cause has a good prognosis, whereas acute brain injury, hypoxic, anoxic encephalopathy, or inflammatory and autoimmune disorders are usually associated with poor prognosis. Whereas if the patient had a previous existing epilepsy, that is a good sign and a good marker. And finally, the outcome depends on the ICU quality care you provide them in the ICU, mitigating the reversible factors, looking out for the cause. And there are several scoring systems, but none has come out to be of good in deciding the treatment approaches. So these are my references. Thank you.
take the questions in the end.
Thank you, sir.
Thank you. Sorry?
Thank you, Dr. Paliwal, for this crisp and very extensive presentation in limited time.
Thank you, ma'am.
I have two comments to make. Firstly, even if the seizures are controlled after administration of benzodiazepines, then also you need to give the second line drugs, because the duration of the effect of those benzodiazepines will be very brief. So you have to in any case proceed for the second line drugs. And secondly, the point that I will actually need to emphasize is that do not underdose the patient, because at times the clinicians are actually so scared of giving all these anesthetic agents, so they end up giving these agents in a lower dose. So the status is not going to end as such, and rather it will progress to the irreversible stage of the status. So always be careful about the doses.
I truly agree with you, ma'am. In fact, in interest of time, I had not mentioned the causes of failure. Of that, the most common cause was the interruption of the drug because of the apprehension of the.
Right.
Thank you, ma'am.
Right. So any questions from the audience?
Thank you, ma'am.
Acumen and Gilman and other pharmacological books, IV xylocaine infusion is written and still it's been written for status epilepticus. Though I've never ever used it. I've used it for chronic neuropathic pains, but never for status epilepticus. Any experience with that?
Madam,
Xylocard.
I also do chronic pain and palliative as well. So I had used in those indications, but I have never used in this. And the current task force guidelines have not mentioned the lignocaine. I had gone through that. So pardon me, I have no experience on that.
Thank you.
Thank you, ma'am.
So one thing I like to highlight that these days in refractory patients we are also doing surgical correction.
Yes,
That
our
at
center
our
had performed
we are doing.
our center had
Mahatma
performed 2 such surgeries.
And they are successful, and patients get relieved of their pain and agony.
Absolutely right, ma'am. Stereotactic surgeries are conducted here at AIIMS Jodhpur. Yeah. Okay. Thank you, ma'am.
You have any experience with ketamine? Have you ever used ketamine for
Uh,
this state? Because like earlier, it was written everywhere that it can precipitate seizures.
Current literature doesn't say. In fact, some few are coming up as a therapeutic modality in refractory status.
When we were residents, we were told that don't use ketamine, increases ICT, it has convulsive potential. But since last 10, 12 years, literature has come that it has got anti-epileptic role and a neuroprotective role because it maintains the blood pressure, systemic vascular resistance. That is its advantage.
Yes, ma'am, I agree with you.
And
And
moreover,
it is
like
I had mentioned in my presentation as well, the dose starts at 1.5 to 10 milligram per kg per hour infusion.
and moreover, where we are using ketamine, we may not have to ventilate the patient always. In situations where you use thiopentone or propofol, then we definitely have to ventilate the patients.
Sir, this is the best part of the ketamine, that it protects the airway. But overall GC will definitely have a.
Sir, so I have a comment to make. So we had a case of super refractory status epilepticus patient, and we had tried all therapies, and it were not. I mean, they were not at all useful. So finally, we had to opt for ketamine infusion, and after almost 24 to 48 hours of ketamine infusion, the seizure stopped. So in pardon.
What dose?
I exactly don't remember.
1 to 1.5 mg ketamine.
I think 1 milligram per kilogram per hour. Yeah, that was the dose.
Actually, ketamine has a added advantage of having a distinct mechanism of action.
Yes, NMDA.
After those mechanisms for the failure of seizure control, they are actually working. So since this has a different mechanism of action, this is going to work
Yes,
after
ma'am.
your conventional anesthetic agents are not
Not
working.
working.
It does not cause hypotension. That is an
Added advantage. Yes, yes. Thank you for.
The guidelines that you are talking of, it says that if you use it even before thiopentone and propofol, it is more effective than those two drugs.
Sorry, I didn't get it, sir.
like if you are using ketamine before even trying thiopentone and propofol, it is very effective in controlling the seizures.
Sir, you are informing or you are asking? I am not getting it.
It is just a comment.
Okay, comment.
Just a
Okay,
comment.
thank you. Third line agents, as per they have said that all are equally effective, but definitely ketamine has a lot of advantages. So we may prefer, especially patients who have hemodynamic instability or patients have some respiratory issues, those with bronchospasm, they may in fact benefit from the added advantage of ketamine or bronchodilation. Sir. Thank you. Thank you.
I would like to thank you, our esteemed faculty and esteemed chairpersons, and I would like to request them to collect their momentum whenever they feel free to leave the venue. Knowledge on a very important topic of VA ECMO.
Yeah, good afternoon all. Am I audible?
Yes, Niranjan, you are
Good
audible.
afternoon all. Okay, first of all, my extreme apology to the entire organizing team. So to put extra pressure on them to go on this thing, create link and other things. So anyway, I was going through the previous lecture. They were all such a knowledgeable session. So we'll quickly go into the topic, which is like the VA ECMO. Now, VA ECMO or any ECMO per se, it's like it's a hot cake for everyone because of three things. One, we deal with the sickest patient. Second thing, for hospitals, it is a lot of revenue, and of course, for the patients, it's a lot of stake. Okay. Now, without wasting any time, now the topic they have assigned to me is I'll try to demystify or will try to understand how rationally to select VA ECMO patients.
Niranjan,
So, yeah,
Niranjan,
please.
we are not able to see your slides.
Oh, sorry, I'm extremely sorry. I try to share. I'll stop sharing and again, sir, let me. Is it visible now?
Yes, sir. Yes.
Okay, fine. So, sorry. Now, quickly into the topic, we'll try to understand. So, the when exactly or where exactly to rationally select a patient, the indications, the cardiac indication, non-cardiac indication, and timing, and so on so forth. So quickly we'll go into the again I told you the cardiac and the non-cardiac conditions of the indications of the ECMO. Then the rational way how you the stepwise how you select these patients, and more important is which modality is to be used. Now there are various sub modalities of the BA ECMO. We'll go in a little bit and we'll try to understand. So now there are grossly two indications of ECMO. Now I'm straight going into the topic proper. So one is the cardiac. The most common cause it's being used is the cardiogenic shock. Among cardiogenic shock, again, acute myocardial infarction is the foremost cause for which the ECMO is being very commonly used. There are other conditions as are there, but it's the most of the studies they are in the range of the acute myocardial infarction. Over last 5 years, there are three studies, the robust one in NEJM, one in JAMA. So they are published regarding the outcome of the ECMO. So that is one area we'll try to understand, and other non-cardiac indications we'll see. So like centers adapt the ELSO recommendations. Now let's see what ELSO says. Cardiogenic shock, and very vaguely also mentions the cardiogenic shock prior to patient go into a irreversible organ failure. There are some recommendations among the cardiogenic shock. We'll try to understand. Then there is one more area which is in fact the controversy area I like rather that discuss fast is the non-cardiogenic causes. Among the non-cardiogenic causes is the most studied area or the recently the discussion is going on is the septic shock and trauma and hypovolemic shock. Of course, in trauma and hypovolemic shock, there is no robust indication. Anecdotal data people are using here and there and specific indications, but in septic conditions, people use the usage is happening since last 20-25 years. So the recent review article, the which collected the maximum near about 3,000 patient data. So this is a the Chinese study which has accumulated all the data. Now grossly, this is divided cardiogenic or the septic shock into septic shock with preserved cardiac function, and second thing is the septic shock with either overt or covert cardiogenic cause. Either is a predominant septic cardiomyopathy or there is a part of the septic shock if it is contributed due to cardiomyopathy. And the shocking result is 85% of the septic shock, they might have mild to moderate or maybe severe septic cardiomyopathy. Now, from there, the theory or the hypothesis of the role of VA ECMO that came into mind of the people to think. Now, let's see how people have used over time. Now, in the Journal of Intensive Care Medicine, they have collected near about 1800 patients data, and so they mentioned so the outcome is still varying because it's a retrospective analysis. People have used in septic shock in various way. The timing and other things are not very specified. Some studies in cases they've used within 3 hours. People have used up to 3 days. So there is no uniformity of timing. Now, regarding the inotropic score, people have used from mild to moderate to severe inotrope requirement. So they came with the following conclusion that it is feasible. They do not recommend right now, but it is feasible depending upon the case to case. Now, ECMO can be considered again. They do not mention recommend. ECMO can be considered in septic shock patients in patients having concurrent cardiogenic shock. So now how to detect that subset of patients among septic shock who are going to be beneficial from the ECMO? Patient having ejection fraction less than 35 or cardiac index of less than 3. Some centers they take like 2.5 also. We take 2.5. Lactate, either it is more than 4 or the lactate dynamics, the rate of increase is more than 2 every hour, that they take as a tissue hypoperfusion. Inotropic score, if it is more than 75, and after adequate fluid resuscitation, if your patient is still not responding, then ECMO can be considered. So this is what I thought to discuss in septic shock. People might be thinking, why is discussing VA ECMO in septic shock? Don't worry, we'll go into cardiogenic shock in details. So now what is the current position paper of ECMO in septic shock? Now in pediatric population, way back in 2017, the American College of Critical Care Medicine and Survival and the Society of Critical Care Medicines, they write the line, you can read, they recommend ECMO. So in septic shock in pediatric population that came as a recommendation. But in adult survival sepsis campaign guideline, they do not recommend. Again, I'm making it very clear right now. They do not recommend, but the suggestions are there. Anecdotal data is there. People are using here and there in septic shock. So this is one area. Okay, I thought it's very interesting. People are using many a times because septic shock patients we are left with no choice. That is the reason we go with it. Now the main issues of the VA ECMO, the major chunk of the patients they come from the cardiac etiology or the cardiogenic shock. Now how to specifically select patients among cardiogenic shock patients who are going to be beneficial from the VA ECMO? There are two things. One is the indication, or we have a specific criteria how to select the patients, whether they are there is indication, that is the indication chart, and second is whether it's going to help those patients or not. Again, we need to be very clear. it's indicated. Second thing, we need to very clear, it's going to help. You may get 10 calls for VA ECMO who may require, whom all of them may satisfy the criteria, having shock, lactate high, ejection fraction low, you might be thinking will be, but you need to see outcome scoring. Now we'll go into details about the indication, then we'll go to the outcome scoring. So your patient must satisfy to indication. Second thing, at least outcome score should show minimum more than 45% or 40% of outcome. Below it, it's kind of futile. Even if it is an indication will be there, they may not come out of the ECMO. Now, ECMO being a resource limiting thing, and it's like it's a involves a major revenue. That's the reason its selection is very important. So among cardiac category, so again I told you the acute myocardial infarction, that is the most common indication which every center they encounter. Among there is a selection. The European Society of Cardiology, they have clearly mentioned the recommendations among acute AMI patients. Second is the acute cardiogenic shocks due to myocarditis. That is one area where the outcome is extremely good. We know you have an inflamed myocardium, so which is having a low ejection or low output state. So give rest and treat the myocarditis either with steroid or with IVIG. Usually they do revert. Uh, then again, reversible arrhythmias. So these are the patients, acute post-cardiotomy patients, the patients coming from your OT. They can come with ECMO or they may require ECMO in the ICU. So this is again the set of patients where they do extremely good if you give a VA ECMO and support them. The next comes the patients where you do not find a like end to recovery, or it's called as a bridge to transplant. Specifically patients with the DCM, dilated cardiomyopathy, or CSD patients. So for them we put on ECMO and the next destination will be heart transplant. So there are few other conditions. Then myocardial dysfunction, inflammatory response to drugs, to toxins. Many times patients with hypothermia, they do present with low ejection fraction, low output, and they do extremely good with the VA ECMO. So that is the subset of patients. Now, as I told you, we will try to rationally understand in specifically which patients among the cardiogenic shock you should alert your ECMO team, or you should give a call to the nearby ECMO center. So to understand that, I thought I'll take 30 seconds to 1 minute of your time to explain the cardiogenic shock. Again, I'm not going to the definition. Definition says it's like systolic is less than less than 90 mmHg, oliguria, lactates increasing, cardiac index so decreasing to less than 2.5 to 2.2. Those are the very like the standard definition of cardiogenic shock. Now, among them, now which are the patients whom we are going to activate? We'll try to understand. Now this is how the left side is a Frank Starling and the right side is a pressure volume loop. Now this is how it happens. So left side is a normal healthy looking heart which nicely ejects the blood from 180 to maybe 90. You can see the right side in a failed heart or in a cardiogenic shock, okay, the pink line. So how it happens, and the ECMO reverts the PV loop to make the by decreasing the LVEDV. You can see here the middle one is the ECMO supported PV loop. So and with the vasodilator, how it looks like. Now this is the physiologic role. Now coming to exactly to understand how to select these patients. So also mentions among these patients there are three areas of, or the three criteria to be placed how to detect. One is the echo criteria. Second is the biochemical criteria, or your lactates, your perfusion pressure, urine output, and other things. And and you need to see the reversibility of the disease. So these are the three conditions to be satisfied to consider for the ECMO. Among them, so first you need to see the cardiogenic shock. So cardiogenic shock, again, I told you the cardiogenic shock standard definition says that, but not necessarily all the patients of cardiogenic shock will require ECMO. Okay, first we need to treat, otherwise So who are those patients may get benefited from the conservative management is clearly defined by the a staging called as a sky staging. That is nothing but the Society of Intervention Cardiology. They have given this sky staging. Now I'll go quickly into it. Sky A, that means patient is having a low ejection fraction state but not in shock. B again, it's like the beginning of cardiogenic shock where vitals are all being maintained, lactates normal till now, not requiring vasopressor is sky A and B. Across world, even also they use this classification to decide whether to go for V ECMO or not. So it's very clear A, B, no question of ECMO. Now let's see C. Sky C, otherwise they say it is a classic cardiogenic shock. It's the beginning of inotrope. It happens in our cardiac ICU. A patient came with MI either before or after stenting. They may be on vasopressors. Up to that thing, it is fine. So if the vasopressor requirements creeps on, it's increase, urine output decreases, lactate keep on increasing, then that is the stage to consider, not to initiate ECMO. That means there people further classify sky C to early sky C, late sky C. So there are nice studies. People try to initiate ECMO in late sky C versus sky D. So now the conclusion came, if you are using in the late sky C, that means your lactates are more than 2, vasopressor requirement is going high, the dynamic indication, along with the echo criteria, then they found the outcome is slightly better compared to when they started in sky D. Now this is the pictorial diagram. Again, I told you sky A, beginning of cardiogenic shock, all may be satisfying the cardiogenic shock criteria, but again, they are in the A, not necessary. B, again, they are still not on the vasopressor. They are still, we can tell them, okay, boss, you may recover by tomorrow, day after tomorrow. Now, we will be little worried when they enter into sky C. That means they are requiring the vasopressor, the lactates are going high, urine output is coming down, C. So either, then it's the clinical decision whether you still go pumping high with the vasopressors or the inotropes, or you start thinking any mechanical circulatory support. Now the question is, should we go for ECMO in all the patients? Not necessarily. So there is a decision tree I will be taking in the last part of my presentation, how rationally to select among other mechanical circulatory supports, like we do have IABP, we have Impella, we have ECMO. Now each has its own pros and cons. So we'll see how to decide. Then comes to sky D. So D, where the patient is deteriorating, the vasopressor requirement is going high, patient is already on ventilator, definite indication without asking. Then the last is a sky E, no point, because you are already in the irreversible phase of sky of the cardiogenic shock, already renal shutdown happened and patient is already on a ventilator. So now according to the shock, so there is a very precisely either in the late C or early D, or in the late D, but at least we should not go to E stage where we'll try to give the mechanical circulatory support. So this is how, according to shock, we very precisely monitor these patients when exactly to give. Now, so if you delayed or these patients, if they went into sky E, now how to know that these patients may not get benefited from the ECMO? Either if they are on since 1 or 2 days, they are on very high dose of vasopressors, lactates are already in the range of 10, 15 or 20, prolonged hypertension. So if at all you are getting a call, so honestly you can say, so probably your patient is not going to improve with this costly treatment, sir. So it's better to avoid. Now this is the shock wise how to select. So this is the indications as I discussed. Now second comes to now if your patient satisfies the indication criteria, then what? Do not jump and offer ECMO. So please see whether your patient is going to get benefited or not. So across all, there are various scoring systems people use, but also uses this standard scoring or the outcomes score that is there in the Google. You can see in the medical also. So SABE scoring, it takes into account the etiology of the cardiogenic shock, age, especially younger people you can offer a little easily. Then comes cardiac conditions, Then renal, if patient is in a complete renal shutdown or some amount of urine is coming or not, and other organs like how the CNS, how the liver is, it takes into all these points. Now, if patient is having the safe score -5 to +5, that is how we, at Apollo Hospital, Hyderabad, we take or we select these patients. Patient must satisfy indication criteria. Patient should have a safe score -5 to +5. Below -5, still you can use if still is a young boy, still you feel clinically compelled, okay, still I can put this guy and bring out. Then otherwise, so by and large, they may not respond. If we have used still SAPE score of -12, but unfortunately we have lost that patient. So that again, you need to be a little cautious. More than 5 SAPE score, ideally they may not require, or if at all they're requiring very short scores, they may require. In our experience, when the SEP score is more than 5, ideally we ask the team, no, still no, we can wait till probably still there is some amount of conservative management, conservative space to be tried. So now this is the echocardiographic criteria. I told if you have a dilated LV, if your ejection fraction is below 30, usually people take 25%. So depending upon the, it's not isolated one entity. You need to see the entire spectrum. How clinically patient is doing, how the shock is worsening, how the lactates, metabolic, and the biochemical parameters. Everything need to be taken into consideration before taking. Now this is what I told you, the decision tree. So this is what is the crux of my presentation, how precisely we decide that we are going to put this guy on a VA ECMO and we can give some hope to the family. First is that you see the initial screening. You will get a call for VA ECMO. Now your system, your juniors, they all should be very well aware of, okay, fine, I need to collect all these data. The initial blood gas, okay, see the lactate, see the metabolic profile, the bicarbonate level. Then second is all other advanced. Is he on ventilator? Is he on being monitored with other things? The vasoactive, the vasopressor, inotrope requirement, whether they have optimized the preload or whether they have treated other conservative management or not. You see, then urine output, lactate, just I told 2, 4, more than 4. Variously people use. We have used ECMO for even at lactate 1 also. I'm not always telling that wait till lactates are 4, but worldwide people use lactate more than 4 as indication. So this is the step 1. Now, if you got a patients, now this is the step 1. If all the criteria or majority of the criteria are met, then what? Second, C, is the shock refractory to conventional? Now this line I always tell my team, so try everything so that such costly treatment, such a resource intensive treatment can be avoided. Okay, we have to have sympathetic for the families, for the patients. If at all there are any space to be tried as a conservative management, we always keep trying. We always should try. So if the answer is no, no sir, they have already tried everything and right now they are trying to reach our ECMO team, then the next question is go to step 3. That is check your hemodynamics, check the 2D echo, and of course, many times before giving a call, they would have done a 2D echo, they would have documented how the heart is doing, and they will document the reversibility. Either patient came with a MI, they are planning to put stent. You know, your hospital is having an extremely good the team of cardiology. Only what is needed is this guy should reach the cath lab. Okay, right now how he will go? Having 30 ml NORAD, urine output coming to 5 ml, lactates are 10. So you need to do something so that you should set this guy to the cath lab and they'll plan to put some 1, 2, 3 stent, and then you can expect the myocardium, stunned myocardium again to slowly pump. So this is how specifically in cardiogenic shock there is a stipulated the decision tree that this is how it helps. But ultimately the clinician decisions. So not necessarily all the criteria should be fulfilled to initiate ECMO. Then, as I told, the non-cardiac conditions like specifically patients who are likely to undergo high-risk surgery and airway surgery, mediastinal surgery, they may require the bypass. ECMO is the hybrid or the advanced form of the cardiopulmonary bypass. Then trauma, as I told you, hypovolemic. So again, I don't want to go into the controversy, but still there are anecdotal data. So people have used ECMO and people they have sent home these kind of patients. But again, it's not a recommendations to use in trauma or hypovolemic shock. ECPR over time, over last 5 years, there are 5 good, nice trials are there. The recent trial they came with conclusion that if ECPR is beneficial, again that is again of course it's not a non-cardiac condition, but it's a different setup basically. If your patient is having a, shockable rhythm, then probably you can still try if your conventional CPR is not helping. And of course, we all know 2025 SCLS, they have very clearly mentioned it is ECMO ECMO. So in 2015, it was vaguely mentioned. 2020, it was somehow suggested. Then comes core pulmonary, massive pulmonary embolism. Again, massive pulmonary embolism. It's again you have to understand. Look, there is some clot sitting over at the outlet of the RA in the pulmonary artery. Now, what is needed is you need to bypass the circulation. Now, anyway, we are going to put them on high dose heparin. So the clot lysis will happen as a collateral benefit to your ECMO run. So this is again, it's a win-win situation when you put a VA ECMO on this kind of patients. Severe pulmonary hypertension, that's again one more indication. Toxicity worldwide, everywhere there are cardiac poisons. So people use, there is a long list of toxins and drugs where VA ECMO is having clearly proven mortality. Then comes, so by now we understood where it's
Niranjan.
indicated and
Niranjan?
yeah, last slide.
Yeah, please hurry up. Thank you.
Yeah, I am going to conclude. So again, precise selection, you have to see etiology, whether it's reversible or not, and the decision tree. So that's what finally it matters. I hope I did justice to that time. I like to take any question if at all is there.
Thank you, Niranjan. Thank you. Thank you so much. And unfortunately, he's taking a lecture on ECMO and he got busy because of ECMO only. So he could not come. And we are missing you. And I hope you will be there next time surely.
Thank you so much. Thank you. Yeah. Bye-bye.
Yeah. Bye. Thank you. Thank you, Niranjan.
Yeah.
And routing back to neurocritical care, let's have a brainstorming session with a case discussion on the topic of brain death and family counseling.
We are honored to invite our esteemed panelist, Dr. R.K. Mani Sir, Director Clinical Service and Chairman Critical Care and Pulmonology, Yashoda Hospital. Dr. Chitra Singh, Professor Anesthesia, Trauma Center, SMS Hospital, Jaipur. Dr. Vikas Gupta, Additional Director, Neurology, Fortis Hospital, Jaipur.
Dr. C.S. Gaur Sir, Senior Consultant, Critical Care SDM at Jaipur. Dr. Ravindra Sisodia Sir, Clinical Director and Associate Professor of Neuroanesthesiology from Mahatma Gandhi Hospital, Jaipur. I would like to extend my welcome to the honored presenter, Dr. Nupur Irwin Sir, a consultant intensivist at CCM from Critical Care Medicine, SDM at Jaipur.
Good afternoon, everyone. So I'm very thankful that I've been asked to moderate this discussion on brain death and family counseling. It's a very important topic for all of us. I say important because one, we know that the patient has suffered irreversible brain damage from which he's not going to recover. Number two, we still have to manage this patient very precisely. We have to optimize him for certain tests, and we have to perform those tests. On the second front, we are dealing with a family which is emotionally very vulnerable because the feeling that such a catastrophe has happened in the family has not yet sunken in. And thirdly, it has got a lot of medico-legal implications. So with that in mind, I commence with the case. I welcome our panelists. So here's a 28-year-old gentleman, previously healthy with no significant medical history, was involved in a high-speed motor vehicle collision at 6 p.m. while riding a motorcycle without a helmet. He was the sole rider and collided head-on with a stationary vehicle. Bystanders reported immediate loss of consciousness at the scene. He was immediately rushed to the nearest hospital. His initial GCS was 3. He was intubated for airway protection and referred to the higher center. Vital signs en route to the hospital included a blood pressure of 90/50, a heart rate of 110 beats per minute, a respiratory rate assisted at 12 breaths per minute, and oxygen saturation of 92 on 100% FiO2. On initial presentation at our emergency department, upon arrival, the patient reached to us at around 11 p.m. The patient was hemodynamically unstable with signs of hypovolemic shock, likely secondary to the associated injuries. Physical examination revealed multiple lacerations on the right side of the scalp, bilateral raccoon eyes, and CSF leakage from the right ear. Pupils were fixed and dilated bilaterally at 5 millimeters with no response to light. There were no spontaneous movements and deep tendon reflexes were absent. The associated injuries include a fractured left femur and abdominal contusions, but no active intra-abdominal bleeding on fast examination. So the initial ABG that was drawn in the emergency department showed a mixed acidosis with pH of 7.01, a PCO2 of 50, a PaO2 of 80 on 100% FiO2, and bicarbs of 14. Lactates were 12 and hemoglobin was 7.2. This was the initial CT scan, which showed a large hemorrhagic contusion in the right frontal, temporal, and parietal regions with mass effect and herniation. The cervical spine CT did not reveal any fracture, but there was soft tissue swelling. The chest and abdominal CT showed bilateral pulmonary contusions, bilateral infiltrates suggesting the possible aspiration, and a small splenic laceration. The option for decompressive craniotomy was deferred by the neurosurgeon in view of poor neurological status and unstable hemodynamics. The patient was resuscitated and was shifted to the neurointensive care unit. In the ICU, the patient remained in shock, requiring a stiff dose of norepinephrine at the rate of 0.5 mics per kg per minute. Hypoosmolar therapy with hypertonic saline was continued to target a serum sodium of 145 to 155, aiming to reduce cerebral edema. Sedation and analgesia with fentanyl were used, along with mechanical ventilation in volume control mode. Empirically, piperacillin, tazobactam, and clindamycin were initiated. Serial neurological examination showed no improvement. The GCS remained 3. A repeat CT head after 12 hours demonstrated worsening cerebral edema, and the temperature was 99 degrees Fahrenheit. Despite maximal medical therapy, the patient did not show any neurological improvement over the next 24 hours. The patient family was counseled about the severity of the injury. So with this background, I would first like to ask Dr. Mani, sir. So this is the usual case scenario that we get. We have got a very limited knowledge about how the patient was managed in the primary setting where he was first taken. We did not know the drugs that were used to intubate the patient and the doses in which they were used. And there is already a 5 hours delay from that hospital to our hospital. So in such case scenario, what should be the ideal time between the primary brain insult and from when we should start evaluating the patient for brain death?
I think guidelines state So guidelines state 6 to 24 hours.
Fair
You know the time given for stabilizing. For instance, you can't do apnea testing without getting the BP up, and with NORAD the BP has come up, but then you are left with confounding factors, like whether sedatives were given earlier or neuromuscular blocking agent, or there was any suspicion of any toxicity, alcohol, So if you can exclude confounders, and there is clearly on the CT scan there is a devastating brain injury, you can decide on apnea testing even before 24 hours. Okay. Depends on at what point in time you're convinced there are no confounding factors.
Okay.
Because you can stabilize the BP within a few hours.
Yeah.
So there is no point in delaying the consideration of brain death if you have excluded confounding factor. This is what I believe. There is a onus on us to consider brain death early and share with the family, and also the need for apnea testing, and get over with this at the first sign of likelihood of brain death.
Thank you, sir. So yes, as sir clearly pointed out, here's what the guidelines state. Now, my next question, just for the reference for our junior doctors, I would like to ask Dr. Chandrasekhar God, what actually is brain death?
Well, actually, brain death is complete loss of all the functions of the brain, like respiratory as well as cardiac function. It is permanent because there are no chances of recovery. So it is a kind of death to the brain stem, which leads to the permanent damage, total anorexia, and I mean GCS is 3 or yes. So it is absolutely irreversible condition of the brain. Yes.
Okay, so the important thing what Dr. Chandrasekhar has mentioned out, he has mentioned the term permanent. It is an irreversible condition. So that has to be taken into consideration. So now I would like to ask Dr. Vikas that are there any reversible conditions that closely mimic brain death that we need to keep in our mind before we proceed on for brain death evaluation?
Yeah, there are many brain death mimics, like drug overdosage, benzodiazepines and opioids. We see very commonly in ICUs. Then there are metabolic and endocrine encephalopathies, hypothermia, temperature, core body temperature less than 35 degree centigrade. Then hypovolemia or shock, locked in syndrome may mimic. Then certain poisonings like snake bite, botulism, they can mimic brain death. And GBS and fulminant neuropathies may also mimic brain death.
So, yeah.
See, crate bite is very strongly associated with, I have seen myself, absolutely mimics. And Guillain-Barré, atypical Guillain-Barré.
Yeah.
And there are case reports in the literature, pediatric literature particularly. So they can closely mimic, so we have to be alert.
Yeah, sir, here I would like to share a case of fulminant GBS that we encountered. Actually, the patient was referred, not referred, he took Dorama from some other hospital, just happened to be the real brother of a ward boy that worked in a hospital. So he was counseled that the patient's GCS is even V1, M1, he has got dilated, pupils are bilaterally dilated and fixed, and there is no respiration. So you can take your patient home, what they commonly say. But he wanted to give it a shot, so he brought it to our hospital. While I was examining the patient with my senior neurologist, what we noticed that the patient was trying to respond with a slight flicker of his eyelids. So we tried to ask him some certain specific questions like कि आपको हमारी बात समझ में आ रही है तो एक बार पलक को झपके. He did that once. Then दो बार पलक को झपकी, then he did that twice. We happened to get a NCV done, and it was severe demyelinating form of GBS. He had got bilateral third nerve palsy, for which he had bilateral ptosis, and the pupils were dilated and fixed, but of course the respiration was involved. He was given both plasmapheresis and IVIG, stayed with us for around 4.5 months, but he fully recovered. So that GBS was an eye-opener for all of us, particularly when it was taken a discharge from a tertiary care hospital in the close vicinity.
Cervical injuries also mimics the same.
So as Dr. Vikas has pointed out, these are the common brain death mimics. Now, before we start thinking about doing an apnea test, so I would like to ask Dr. Chitra, how do we optimize our patient for that particular evaluation, or what are the prerequisites that needs to be met before even we go and try and perform that test?
Before taking your question, I'll just like to add on for the juniors maybe working in this line. As they have asked about the what is the time duration, so they say it is up to 24 hours. But sometime if you see that the patient is in diabetes insipidus, the most important organ, the first organ to go in brain dead is posterior pituitary, because it has got hypophyseal arterial supply from internal carotid, which are extradural in origin. So the patient lands up in diabetes insipidus, and he'll present to you in a hypovolumic shock with large amount of urine output, and GCS will be less than 3 or in between 3 to 5, large urine output, hypernatremia, hypovolumic shock, and you see that this patient will land up in brain death. More or less, this is one of the clinical criteria if you are having the patient. Then this is one of the clinical criteria where you can see that yes, this might be the patient, and you can suspect it to take up in your protocol at a little earlier stage. Right. Besides this, if as he has already, sir has already pointed out, there are few conditions which mimics brain death. They have to be ruled out. One thing. Second thing, it is the loss of entire brain along with the brainstem reflexes. So the entire brain has to be, which will be, you have to document that. Maybe your neurologist or a neurosurgeon will document that the patient is in irreversible coma. That is, the entire brain has gone. And after this, the DNC, diagnostic neurological criteria, has to be performed. Now coming to the question as asked by Dr. Nupur, what are the prerequisites? As said, hypothermia should not be there. The patient should have a normothermia, 37 degrees centigrade, but less than 35.5 degrees centigrade is not acceptable. Okay, you have to go for rewarming for 24 hours, and then you can go for DNC criteria as suggested by the guidelines. One thing. Once you have gone for entire brain and the brainstem reflexes, then you can have the second thing which will be there, that your patient is in hypovolumic shock, as I have told. So you have to give fluids. And the fluids which you want to have will be governed by your electrolytes. What kind of fluid have to be given. Initially, after resuscitating, you have to check out if the patient is landing up in brain dead, then electrolyte will be your guiding fluid once the patient is resuscitated well. After this, you have to rule out Guillain-Barré, you have to rule out botulism, you have to rule out locked-in syndromes. You have to have patient vitally stable with urine output of say 1 to 2 ml per kg per hour. Then any drugs, you have to check out. If there are drugs, then at least 4 to 5 have. If there is a documentation and you have an antidote, go for an antidote. If you don't have an antidote, wait for 4 to 5 half-life to pass away, let the drug eliminate, and then you can proceed for DNCs. Secondly, if the patient is in dysfunctions, liver dysfunction or renal dysfunction, correct those parameters and wait for a longer time. Let the drug be eliminated, and then you can proceed for DNC criterias. Talking about blood pressure, the nursing, we say it has to be more than 100 mm systolic, but for us, the mean arterial pressure should be more than 65 mm of Hg. And if the patient is on ECMO, then I'm less experienced in ECMO. I have brain death certification with ECMOs, but if you're, as the literature suggests, if the patient is on ECMO, VV it is the same, VV ECMO it is the same, that is more than 65 mm of Hg, more than and equal to. And if it is VA ECMO, then it is more than 75 mm of Hg. Then other thing could be if the patient is in encephalitis, that has to be checked. Then your hospital should have a brain dead committee available at your center, and that should be certified. That is another important criteria which has to be taken in account before declaring the patient brain death, and that certificate should be reviewed also. Right?
One more question I would like to ask you, Dr. Chitra, as you have mentioned specifically about diabetes insipidus, which will cause hypernatremia. So we have to correct the sodium. Is there any guideline as to how rapidly we have to bring down the sodium, in what time, or
no, it's actually a race against time. If the brain will herniate, there will be sudden parasympathetic surge, and you will not be able to make up for the patient and anyway how these patients are vasoplegic also, right? So if you say correction, it is like what we do at our centers is we are with the checking for all the parameters of say the patient is not going in overload, he should not end up in edema. We are continuing checking for the parameters for the, as the lecture was also taken on that, and we give a little extra what the endocrine people suggest or what the neurologists suggest. And how do we correct is like as we have a formula of hypernatremia correction, that you have whatever is your sodium minus 140 upon 140 multiplied by total body weight. And this we divide in 1 day or a 2 day ration and add it to the maintenance per hour. So that ways we go on correcting, and corresponding monitoring of fluid overload has to be checked.
So
glucose is one more important factor which you might miss in a ventilated patient. So glucose has to be maintained between 100 to 150 mg/%, right?
Yeah, so the list of prerequisite condition is quite exhaustive, and I think Dr. Chitra has elaborated it very nicely. So over the next 48 hours, the patient was off all sedations, hemodynamics stabilized, and the patient was off norepinephrine, maintaining a MAP of more than 75, and the core temperature was 37 degrees Celsius. Oxygen requirement came down to 40%. The labs are as follows. The sodium was 150, the glucose was 124, BUN 42, calcium, ionic calcium was 1, magnesium 1.9, the ABG was fairly within the normal range, the thyroid profile was normal, and the ammonia was normal. The urine tox screen was negative, and the blood alcohol levels were within the normal range. But the only issue the patient was having, that he was having copious tracheal secretions which required frequent suctioning. So here I would like to ask Dr. Vikas that neurological examination is very crucial for brain death evaluation. So can you briefly tell us what are the components of precise neurological evaluation in context with brain death and DNC?
We do in every patient GCS, then there is no response to any noxious stimuli, no facial grimace, spinal reflexes, we do not count them. Then we go for the brainstem reflexes, pupillary reflex, then the corneal reflex, doll's eye reflex, cold caloric test, gag reflex, and then we go for that apnea test then finally.
So one thing I would like to point out to our juniors, that please do not check for doll's eye response until you have ensured the stability of the cervical spine. We did that in our patient, so we went for a doll's eye examination, but the only precaution you have to take before doing a doll's eye examination, that your cervical spine stability has to be ensured. So now my next question, a very important question for all of us, is how to perform apnea test correctly. I would like to ask this to Dr. Ravindra Sisodia.
So as has been elaborated, like all confounding factors should be confirmed for apnea test, and brainstem reflex, when it is proven the cause of coma has established and the brainstem reflexes are not there, then the final test, which is the apnea test, should be performed. So for this, one pre-oxygenate the patient for 10 minutes to ensure the adequate oxygen level, and take a sample of ABG, and in ABG the PaO2 should be 200 or more, and simultaneously you should watch for a PaCO2 level also. The patient should be in normal cardiac state. So the idea of apnea test is just to look for the brainstem reflex for the hypercarbia. So when the CO2 will rise, then if the brainstem is functioning, then there should be a stimulus of respiration by the brainstem. So for apnea test, after pre-oxygenation, then ventilator can be disconnected. One way is disconnection of the ventilator, and apnea flow of oxygen should be given at the rate of 4 to 6 ml per hour. Other way is put the patient on the CPAP. Another third method is put the patient on the flow inflating bags like Bain circuit, which is having valve where you can give PEEP also. So these are the ways how you can perform the test. So there is no drive of respiration by ventilator this time. So let the CO2 rise, but patient should be oxygenated by the flow of oxygen. So let not be hypoxia, create hypoxia to the patient. So wait for the 6 to 8 minutes of EVG at the end of this time, and meanwhile watch for the any respiratory effort, abdomen or the chest. So if there is the test can be terminated if there is any sort of effect of respiration. One, if there any observed respiration, or there is hypoxia, or there is hemodynamic disturbances or arrhythmia. In that case, the apnea test should be terminated.
Sir, any experience on performing apnea test on a patient who is on ECMO?
No, I don't. I have not done that in my own practice, but I know the rules. I mean, rules are that you have to keep the sweep gas flow low, 1.5 liters. It can't be zero, unfortunately. You have to keep it low, and then keep the oxygen high on the ventilator, and then the same rules apply. That's right.
Doing the ECMO, the AA, then the lowering down flow will cause the ETCO2 will means PaCO2 will rise fast, and the cardiovascular system can be affected in this case.
The other way, as one of the literature and one of the case reports suggests, that they have increased the carbon dioxide level through the ECMO itself, and they have seen whether there was any respiratory movement. The one which sir has said, and another is this. The other way around is this.
CO2, 20 mmHg from the previous. So we were about to perform the apnea test, but unfortunately there was a catastrophic event where the patient suddenly desaturated to 64%. He was immediately taken on Bain circuit and was oxygenated with 100% oxygen. Clinically, there was no movement of the right hemithorax. So urgent chest diagram was obtained, and it showed a complete collapse of the right lung. An urgent bedside bronchoscopy was done that showed a large mucus plug in the right main bronchus, which was taken out. Following this, the patient was managed with mucolytics, the standard ventilation and position changes, but the oxygenation kept worsening. After 48 hours, the ventilatory settings were as follows. The patient was ventilated at respiratory rate 28 with a PEEP of 14, FiO2 of 1, and a tidal volume of 420. The patient required norepinephrine support at 0.3 mics per kg per hour, but he was maintaining a MAP of more than 75. So all other parameters were in line with the criteria for brain death testing, except that the patient was severely hypoxemic and required quite stiff ventilatory settings. So clearly we were not able to perform an apnea test. So I would like to ask Dr. Chitra, what can we do next?
So if I talk about this case report, you have to, because the patient was having fracture femur, you have to think of fat embolism as per se.
Hello.
Then you have to, because there was large amount of secretion, then there has to be physiotherapy and suction every 6 hourly. And then there was contusions also, so that has also been taken into account. Now coming to, as it is said that a uniform determination of death says it is the entire brain. So entire brain, your etiology in the international certificate of death tells that the patient entire brain functions are lost, and that has to coincide with the pathogenesis of ischemia, right? As it will go to pons. So once it goes to pons, you will have bradycardia as well as you will have hypertension. Once it will go to medulla, then it will have a catecholamine storm. You will have high BPs and all that stuff. And when it is go to the spinal, then there will be a parasympathetic surge. Similarly, when their motor functions, they go as, it will go to decorticate and then decerebrate and then loss of motor functions. So your etiology which you write in your international certificate have to be inconsistent with the brain injury, one thing. Secondly, 2 diagnostic tests as told by the, as told, 6 hours, minimum 6 hours apart, should be performed by 2 different teams, right? And if any one of those, say maybe oculocephalic reflex or the caloric reflex because of the tympanic membrane rupture or the facial trauma, if the complete set of investigations of DNC could not be performed, then the ancillary test comes into picture, one thing. Second, your apnea is inconclusive, then it comes into picture. Third thing is your, that because of the hemodynamic stability, you have to abandon the apnea process. Then the ancillary test comes into picture. Ancillary test, as per se, only ancillary test, you cannot say that the patient is brain dead. You will be sued in the court of law. Or it is the clinical sets which are supported by the ancillary test, right? And the ancillary tests are generally divided into 2. They say either you are checking for the cellular activities and the cortical activities by EEGs, or the evoked potential, somatosensory or auditory evoked potentials, or you are looking for the perfusion in the brain, right? It can be a 4-vessel angiogram, it can be CT angiogram. What were taken by the, in the guidelines is the CT brain, in which it will show diffuse edema, effacement of the ventricles will be there, the grey and white matter cannot be seen properly. It is a hollow skull picture. Secondly, if we talk about the CT angio, if you say, so what will be see in CT angio? That you will have circulation in the external carotid, but the internal carotid artery, after the pitris part of the pitris part, their pathway, you will not see any blood flow there. Then you will have another is a radionucleotide scans. Scintigraphy can be taken into picture with technetium scans. That has been taken as an ancillary test. And then you can have a transcranial Doppler. In transcranial Doppler, all the 5 ICA, basilar artery, and all these arteries are taken into picture. And the blood flow should be absent in minimum of 3 arteries for 3 minutes in same examination. And it is actually the ancillary test also carry a large amount of, each test is having another set of complications, maybe the paraphernalia which is required, or the cost, or you cannot shift the patient, or maybe the expertise. That is one big problem that we cannot. As per law, the ancillary tests are not mandatory if you have gone, in India they are not mandatory if you have gone for the clinical set of DNCs. Okay, diagnostic neurological criteria are fulfilled.
So I think Dr. Chitra has answered most of our questions, including this. That we clearly cannot declare a patient brain dead solely on the basis of ancillary test in the event where we are not able to perform an apnea test. I would like to ask Dr. Mani, what is the stand of advanced medical directives in our country with regards to brain death, sir?
No, there is now legally a valid advanced medical directive execution is possible for every citizen of India, and the procedure has been simplified. That is, you can execute a document stating how should you lose consciousness, how you should be treated, medically treated. So you can put it in the document that you don't want to be ventilated or resuscitated, or in the event of brain death, you would like your organs to be donated. So this is possible. Of course, the penetration of AMD is still very low and the awareness is very low, but this is a legally valid possibility for every one of us. So you can you can execute an AMD anytime in your life. It's not necessary that you got to be terminally ill. It kicks in when you lose your capacity. But you can execute at any time, even in young age, because like Barack Obama has executed one, but Christopher Reeves didn't. So unfortunately, he did have a serious problem. So this is what we can't anticipate: traumatic injury, fatal traumatic injury, or a brain death situation. So you can all execute an AMD.
Yeah, so as Sir correctly said, AMD that meets specific requirements is a legally valid document in our country.
So how to legally validate it? You have to have 2 witnesses, and it can be it should be in the presence of a notary or a gazetted officer. That's all is needed. No more. You don't need to knock on the doors of a magistrate or any court.
Okay, so in the interest of time, I'll just open the questions to the panelists. I think, what are the salient points that we need to remember while counseling the patients now that we were not able to perform apnea test in this patient? Supposedly, we were able to perform the apnea test in this patient. Number one, sir, one question is, do we need a family consent to perform the first apnea test? We don't.
It says you don't need, but you generally inform that we are conducting a test which will document whether your brain activity is there or the patient may have an activity in the brain. You have to take the family into picture a little bit before counseling. You cannot disconnect the way around. It can be in a camouflage language, but yes, written informed consent is not necessary.
Okay. And secondly, what are the basic things that we need to remember while we sit in front of a family which has not yet accepted that the patient has suffered something which is not going to reverse back? Are there certain salient points that we need to remember, something that we should not talk, something that we should highlight, or any experience with that?
One thing which I'd like to say, after your apnea is being performed, tell your patient is dead, he will not come back to life, and let the family members breathe. And all of you, whosoever are sitting in the counseling room, should be on the same page. You should not pass any loose comment. Your body language should speak that yes, the patient has gone, but as the counseling in grief states in the chapters of psychiatry, आप ये नहीं बोलेंगे आपके दुख में हम शामिल हैं, उनका दुख अपनाए. This we have coordinators.
Involve the counselor.
We have coordinators and we teach the coordinators.
Yeah,
There are certain do's and don'ts which you will get on Google. Something you don't have to speak in front of the family. You'll easily get that slide on the Google counseling if you type counseling in grief, right? But you have to allow the family to breathe and tell them that the patient is dead and he'll never come back to life.
Okay, I'll just conclude with a last question for the day for our experienced panelists. What if it's a high profile case, and what if it's a young pregnant female? Is the counseling something changes, or?
See, we don't need to make an exclusion of any high profile, or because the truth is there facing you, and it is in the counseling. You should be very clear that it is brain death is death.
Okay.
One should not introduce any confusion. There's only one death, and this happens to be directly in the brain. You know, even when you die cardiac, you die in the brain, but then this is directly in the brain. That's all the difference is. There is no reversibility after this. And I want to reiterate that although in many countries it is the whole brain death that is regarded as death, in our TOA it is brainstem death. They don't mention any whole brain death. That they have taken from the UK. The same norm, because brainstem death is considered as brain death in our country. Okay, that's why we don't do EEG as an ancillary test. For us it is the 4-vessel angiogram. That is foolproof. You may do transcranial Doppler. It is operator dependent. You may do CT angiogram, but that is also not foolproof. It is the 4-vessel angiogram that is foolproof. You must remember. And then pregnancy, yes, it's a special situation. If it's a very premature baby, not viable at the moment, that's a very difficult situation. The family has to be given the choice whether to continue for the sake of the baby. Okay, somatic support for the pregnant woman. If there is a viable fetus, then fetus can be, it can be delivered. Okay, So this is what it is, but if there is a viable fetus, this has to be discussed with the family. And it's got to be a joint decision, shared decision. Can't be unilateral.
Thank you so much, sir. It was really a pleasure and an honor to have you amongst us today. Thank you.
Just one thing, I'll just add on one thing. You cannot say, oh, general question is कि अगर ये मर गया है तो why these graphics are coming, दिल चल रहा है, ये चल रहा है. So you say they are all organ support. They are not life support, they are organ support. Right? Because we are in a habit of speaking they are life support systems, but they are not life support system. The patient is dead, they are organ support system. Okay?
The World Brain Death Project submitted its report 2020 in JAMA. It calls it somatic support. Okay? It is not life support. Because it's only the organs are being. So this has to be communicated to the family. What you're seeing on the monitor is because of the life support. The body is not alive in the sense of the person being alive. Not that has to be clearly communicated. Very often I see our neurologists writing on the case notes, poor prognosis explained. There is no prognosis after death.
Yeah.
Okay, let's be very clear. Death is death. There is no coming back. There's no prognosis. So we should not use ambiguous language. Yeah.
Thank you, sir.
Only one question. The legal validity of DNI and DNR order in ICU given by the relative, suppose one son and the second son is in America, he is not, he's not interested in doing, and then suddenly he comes to India and says, who has given this order? DNI and DNR order for parents?
Nikhil, this sort of a projection I've been hearing for 2 decades, and I've been practicing DNI, DNR for 20 years. This situation is very rare. So we only talk about the rare situation. Now the thing is, whoever takes responsibility for the patient. See, you take consent from the son who is there. No, you taking consent. You're not taking from who is abroad. So the decision making on the patient is shared between whoever is available and the doctors, the family member available. It doesn't say that you have got to get all the family on board and there can be objection, then you will be. See, if there is a consent for DNI, DNR, signed duly, according to the pathway defined in the ISCCM, IAPC guidelines, then you are all right. Why be afraid of a theoretical situation which doesn't actually happen, which may happen? That can happen in any situation in medicine that's, out of the ordinary can happen. You got to face up to that. What I do is, you ask if there is any other member of the family who is significant and whose opinion is required. And even if they are abroad, you can talk to them on the phone. Or you can have a family chat group, okay, with the doctor. These are all possible now. So, but then, such situations are very uncommon. So let's be very confident. You got a DNI, DNR law, okay, withdrawal withholding law, which is endorsed by the Ministry of Health. You got a draft document endorsed, which is on the lines of the ISCCM IAPC guidelines, which is integrated the Supreme Court legal procedure. So we are all right. We don't have to be too squeamish. I must tell you one more last thing. If there is no organ donation agreed to by the family, you don't just leave the patient to his fate on the ventilator. Because the patient was dead. That is why you asked for permission to donate. Okay? Otherwise, you cannot be. There's a dead donor rule. So you can't say it is only defined in THOA, not outside of THOA. So the patient becomes undead once there is refusal for donation. That is a very specious argument. That's not a correct argument. And that's not agreeable ethically or professionally. So I do regularly disconnect the ventilator, extubate the patient, produce closure, and give the body to the family. Because that's the right thing to do by the body. And I have had no legal problem. On the contrary, there is relief on the face of the family. There is a good atmosphere, good family doctor relationship. And they believe you, they trust you. So this is the outcome we want, isn't it? To re-establish the trust. If you say no, you take the patient, lama, extubate anywhere else, it is not very kind. Okay, it's a very cruel way to. And now the Ministry of Health withdrawal document also states you can take it up. Then you don't have to go through the two panels of an end of life decision. This is death. You have the brain death committee certifying death. That's enough. So after death, why should you go through the procedure declared by the court?
That brings us to the close of truly insightful and enriching session on neurocritical care. A heartfelt thank you to all our faculty and chairpersons for sharing their valuable expertise and experiences with us, and request them to collect their mementos. As we head to our last session of today's evening, that is gastrointestinal critical care. It is often called the forgotten organ in critical care, yet when gut fails, it can trigger a cascade of multi-organ failure. And for us, it becomes a challenging situation. We will be having two didactic lectures on it, and I would like to call upon our respected chairpersons on stage, Dr. Sushil Kalra sir, Director and HOD Department of Internal Medicine, C.K. Birla Hospital, Dr. Sandeep Vaishnav sir, Consultant Gastroenterology, SDM at Jaipur, Dr. Balkrishna Gupta sir, Senior Professor, Department of Internal Medicine, SP Medical College, Bikaner, Dr. Shuchi Mathur, Consultant Intensivist, Rajasthan Hospital, Jaipur, and Dr. Dev Kumar Harkawat, Associate Professor, Jaipur National University. A big round of applause for them.
Hello everyone. Now I would like to invite Dr. Pramod Sarva sir. Topic: liver dysfunctioning in sepsis, practical approaches. Sir, please.
Good evening everyone. I will not take too much time because already we are running late. So in few minutes we will discuss about what are the mechanisms of liver dysfunction in a septic patient and how try to make a practical approach about it. Sepsis is a dysregulated host response to an infection, and it can involve any organ. And when we talk about liver, the peculiar thing about liver is it is highly resilient organ. It has metabolic reserve, good physiological reserve. It acts as a guardian. It filters out the bacteria by secreting opsonins. Acute phase protein act as a opsonins and clear out the bacteria. At the same time, it modifies the inflammatory response and metabolic response. But when your sepsis burden is very high, it get involves. And when you get a liver dysfunction in a septic case, the mortality is very high, reaching approximately 54. In fact, the odds ratio of a patient being a liver dysfunction in a septic case, it is 3.5 times more mortality. So there are various mechanisms. They are acting each other like cause and effect. So suppose if a septic patient has circulatory disturbance and it will lead to a shock stage, it will harm the liver, and the liver injury itself will cause a coagulation disturbance. So there is cause and effect relationship. Similarly, a mitochondrial injury will cause production of reactive oxygen species, and it will damage the liver, and in fact the liver damage itself increase the formation of reactive oxygen species. So these two mechanisms are very central: hepatic inflammatory response and the gut liver crosstalk. Let's start with the gut liver crosstalk. So whenever there is inflammation, it goes to liver, and liver, who is primarily responsible for bacterial clearance and bile acid to protect the gut integrity. Now this gut integrity is damaged, it gets altered, it causes gut disruption. At the same time, the inflammatory mediator released by the liver hepatocyte injury will cause loosening of the tight junction in the gut epithelium. And when you have the inflammatory mediators, they work on the zona occludens, their occluding protein, and the these proteins expression gets dysregulated and bacterial lipopolysaccharide gets free entry to the bloodstream via portal vein. They reach to the liver, and when they reach to the liver, they come in contact with first line of defense, that is Kupffer cells. They modified the inflammatory response by the mechanism of acute phase proteins, and then they clear out the bacteria. This is the normal defense mechanism. Human gut contains 1 gram of LPS, lipopolysaccharide, and you only need few milligrams of LPS to initiate a severe inflammatory response. Now, when there is overwhelming triggered, constant trigger, constant septic burden, that injurious process in the liver causes the trauma, and there are on cellular level, there is expression of NFK beta pathway, which trigger inflammation, and there is ROS mediated mitochondrial dysfunction, and there is lipid peroxidation, and there are many research going on these molecular mechanisms, and some of these players are we already know, like Dexmed. Dexmed works on the TLR4 receptor, inhibit the inflammation by NFK beta pathway. There is LTRA, leukotriene receptor, Montelukast we commonly use. It has anti-inflammatory and liver protective property. Then there is fibrates, PPR gamma we used to do old as a oral anti-hypoglycemic. So there are research is going on. Most of the research is preclinical. The only clinical trials now is a monoclonal antibody against factor 5, complement factor 5A, and it will reduce the interleukin 8 and 10. So there are research going on the micro level. What happens in macrocellular level? The injury apparent in 3 type of mechanisms. First is hypoxic hepatitis. So it occurs within the 48 hours of circulatory or cardiopulmonary insult. You will get a injury markers more than 10 times rise in SGOT-PT, relatively normal cholestatic markers. So there won't be mild rise of bilirubin, and you will get a coagulopathy. Now, in septic cholestasis, the injury markers are relatively well preserved. There is a problem in the bile salt formation, bile secretion. So you will have an increase in the bilirubin, you will have increase in the alkaline phosphate and GGT, but the OTPT level will remain within the normal limit. And the third most characteristic is secondary sclerosing cholangitis, the most rare but most difficult to treat, and the prognosis is very poor, and you may require liver transplant in these cases. It needs to be differentiated with PBS, that is an autoimmune condition. So now, with this knowledge, we try to formulate the practical approach how to deal. The first stage is to identify. We need to monitor signs like jaundice, INR, LFTs. Then we should treat the cause, and the septic liver dysfunction's cause is obviously the sepsis. You need to treat with appropriate antibiotic. You need to have a good source control. You need to support liver by hemodynamic stabilization. So you want to give judicious fluid, vasopressor support, use of steroid if you are having aggressive septic shock and you are getting a high vasopressor support. You want to add hydrocortisone. You want to avoid hepatotoxic drug. There are many common ICU drugs which are we using in the ICU which are hepatotoxic. So you want to go on your phone and you check for the hepatotoxicity potential. There are many common like paracetamol, antibiotics, vanc, linezolid, antifungal, ART, ATT. Then you have cardiac medications like amiodarone, methyl-dopa, ACE inhibitor, anti-epileptics. All are these are liver toxic drugs. So you wanna choose and use it wisely. Now, the third approach will be the early enteral nutrition, because the TPN is very toxic. TPN is very toxic for liver. TPN is very bad for intestinal gut bacteria, because the gut integrity, that is the central role in the pathogenesis of liver dysfunction. And you want to treat the complication of liver dysfunction like renal complication with the help of dialysis, renal support, CNS, you want to use CRRT or coagulopathy appropriate blood product, and then you have some liver support dialysis, CRRT, plasma exchange or MARS that are beyond the scope of this talk. Now, very commonly we see Mucinex. In every liver dysfunction case, we see an acetylcysteine is being given. It has physiological rationale that it has antioxidant property. It replaces the glutathione level. But if you see the meta-analysis, there are very few clinical studies which favor use of Mucinex in septic patient, but you can use it as a physiological agent. Now the UDLIV. UDLIV is very common in every prescription. You have a deranged LFT, and there is no meta-analysis in the adult population. Only chronic cholestatic drug-induced liver injury has a strong meta-analysis, which has good long-term outcome and liver enzymes benefit. Primary biliary cirrhosis or the secondary biliary cholangitis, UDLIV has no role. Now the best upcoming thing is effect of probiotic. These are still in preclinical studies. There are trials about FMT in other cases, but in septic liver dysfunction there are the high potentials. So the take home point is suspect septic associated liver injury in every septic patient who develop jaundice, deranged liver enzyme, new coagulopathy. Prioritize rapid and effective source control, infection control with the help of antibiotics. Circulatory support, review all medications for hepatic septicemia and doses, and monitor liver function closely. That's all from me. If I have some time, there is new studies. This is preclinical study which having a time restricted feeding. So it has that 3-HB, 3-hydroxy beta supplement in the mouse model, that is celiac ligation and perforation models. So they create sepsis by ligating the cecum, and they have shown that if you alter the microbiota and you increase the growth of lactobacillus murinum, increase the 3-HB level, it will reduce the iron dependent apoptosis. There are some gene therapies is going on, lipocanin 2 gene silencing, that will reduce the ferroptosis mediated liver injury, and there is the role of dexmedetomidine acting on the LPS. Thank you.
Thank you. And you have covered all the topics, means pathophysiology as well as all the treatment targets very beautifully and obviously in a very short period of time. Any questions from the audience? So there are a few comments from my side. One is the enteral feeding. So you just told us the negative things about the parenteral, but it's enteral feeding that maintain the intestinal barrier, that prevent the bacterial translocations, and that can reduce the inflammation within the liver. So enteral feeding is most important thing in preventing the hepatotoxicity. Second one is there any kind of role of corticosteroids?
So corticosteroids has no role as per the liver dysfunction, but as a treating septic shock, it has role as per the hemodynamic stabilization and role. So there are some trials about the anti-inflammatory property of using the, but the pathophysiology is very complex. So we have seen the mechanisms when you have anti-inflammatory hepatocellular damage is get prevented, but at the same time it has negative detrimental effect on the gut integrity. So steroid, you wanna use steroid, use it in the septic shock dose in septic associated liver dysfunction. The only is when you have alcoholic hepatitis with moderate discrimination factor more than 16 and you are suspecting autoimmune hepatitis, then only you should use steroid in the recommended dose.
So very well said. Actually, one point is that sometimes patient with autoimmune hepatitis and sometimes with some toxic mediated injury may present in sepsis. So in that case, you can use corticosteroid. And if there is any suspicion of any other drug-induced liver injury, then you can use the N-acetylcysteine in that case also.
Yeah.
But obviously, in pure sepsis, there is